Welcome to the Alliance for Patient Care, an organization dedicated to advancing smarter healthcare policies that empower both patients and providers. Through innovation and advocacy, the Alliance supports stronger, healthier communities.
Hey, good afternoon, everybody. My name is Jennings DePriest. I'm the chairman of the Alliance for Patient Care, and we have a great webinar for you today based in the upcoming CMS rule changes, as well as some on-the-ground experience from a wound care provider working here in Florida on what he is seeing specifically in the home health and nursing home environment, on how these CMS rule changes could impact his ability to provide for patients, as well as the ability of the nursing homes, the SNFs, and the home health organizations to continue providing the best care possible for patients. Alliance for Patient Care has three goals. We're here to provide advocacy and continue advocating for CMS to do the right thing and continue to fund these life-saving products. We're here to connect people across the continuum of patient care. We're here to provide education and make sure that everyone is on the same page and is receiving the best information possible on wound care now, but other issues as they may arise in the future. The CMS proposed rule change, if you're not aware of this, the QR code on the screen, and we can also drop a link in the chat, will take you to the CMS proposed rule change information. They are proposing a payment of $125.38 per centimeter for all types of skin substitutes. So single layer, dual layer, tri-layer, all three would be reimbursed at $125 per centimeter. Now, considering we're currently at a $2,400 on average, depends on products, obviously, per centimeter reimbursement, there is a 95% reduction in reimbursement, which is a huge issue for providers and patients alike. Something to mention, if you are commenting on this rule change, is that this is based on hospital data only. It's not based on office, mobile, or home service treatment, which, as you know, needs a more specialized product. If you are in the sterile environment of a hospital, it is much easier to heal your wound, but it's also much more expensive because you're paying for the hospitalization. So there is an overarching theme here to make sure that CMS is working off the right data. It is a different type of wound in a home health environment or a long-term care environment. And that's just not being reflected in this rule change. The 60-day comment period closes on this on September 12th. So we have a little over 30 days left, I think 35 days. So please get the comments in. Please make sure your patients, your staff are making comments and letting everyone know that this is not an acceptable rule change. This will have extremely negative effects on patient care and on patient outcomes. And we'll touch on more of that with Yvonne as we get into today's webinar. Here's what you can do. One, share this information with patients and other providers. Not everyone knows that this is coming, even when it comes to providers, and certainly when it comes to patients. If you have patients who have been successfully treated with skin substitutes, please have them go share their story with CMS while they're commenting on opposing the rule. It's also really important to call your congressman and your senator. If you need help finding those people, we're working on a tool on the website that will push you through directly to your senators and your representative based on adding your address. But in the meantime, if you need anything like that, please reach out to us. We're here to help. We're happy to help make that connection. Members of Congress do have the ability to call Medicare and advocate on your behalf. Constituent services are a really important part of the federal legislature that is just not utilized enough. So moving forward, wanted to introduce today's guest. We have Yvonne, who is the co-founder and CEO of iCare Mobile Medicine. iCare Mobile Medicine provides mobile wound care and concierge health throughout the state of Florida. He is an expert in the skin substitute space and the wound care space, and it is a pleasure to have him on today. We'll be going into several different items about patient care, about the way the proposed rule change is going to impact not just the providers and not just the patients, but also nursing homes, long-term care providers, and even senior living communities where we see these wounds that could be treated with skin substitutes. So, Yvonne, thank you for coming on today. Really appreciate you coming here to share your expertise. Let's go ahead and get started by looking at what you're seeing currently and what would change if CMS's $125 per centimeter went into effect.
Hey, Jennings, thanks for having me on such an important topic that is very underappreciated. I think it's important to note in the beginning that, those prices that you see on the board are not what the doctor gets to make. A doctor ultimately ends up with about 20% of those payouts. So 20% of 125, you do the math, is not fantastic. CMS is way behind on mobile clinics. Essentially, all the fee schedules have been set up for traditional doctors' offices, where the lobby's full of patients, and as soon as you're done, the next patient is in the room, and that's how you're making an earning. With mobile clinics, it takes me 45 minutes, especially down here in Miami. It's actually more like an hour to get to the patient, and then I am spending an hour with the patient, and then I'm spending another hour going back to the office. So I've spent 3 hours with the patient, but really I'm being only reimbursed for an hour of work. So when you do the math, these proposed changes would effectively shut my company down overnight, the mobile wound care clinics specifically. The traditional office clinics, I'm sure they would still do okay, but the mobile clinics, which is now make up for more than 50% of the wound care, would be effectively shut down. And there's an overwhelming amount of reasons why a mobile clinic would be so much more beneficial than a traditional brick and mortar for many reasons. But there's also a very important topic that I noticed that no one seems to be talking about anywhere. And that topic is the baby boomers are retiring. So the aging population is increasing. And there is a shortage of doctors each year. There's less and less doctors graduating from school and getting into the field for many reasons, because ultimately just doctors are tired of putting up with the insurances. So as it is, we already have a problem of access to care, and in 10 years, that problem is going to grow drastically more. So these changes would effectively decentivize elderly care, elderly treatments overnight. And I don't understand the rationale behind it.
Yeah. Specifically with, mobile wound care, which I know, it's 50% of the market. Can you touch on why that's so important, particularly for the senior population?
So there's a long list of reasons why mobile clinics are so great for patients, especially the elderly patients. One is obviously compliance. So one of the biggest reasons why patients don't do well with medications, they don't do well with wounds in this topic, is because they can't get to the doctors. They're either bedbound or they no longer drive. Their caregivers, their family members are at work. So going to the doctors is a huge, huge burden. And not to mention, even getting to the doctor, then you're waiting several hours there. It's not a quick visit, and you're back home. So compliance is a big issue. With a clinic that comes to your bedside pretty much anytime you want, the compliance is nearly 100%. Now, when the compliance is nearly 100%, you are going to get much better results to begin with. Because again, one of the biggest reasons why these wounds don't heal is just compliance. So increasing compliance, you improve the outcome. Two, it's a great benefit for the wound clinics. When you increase access, you are starting the treatments way early. So you're not waiting until that wound becomes really, really bad. You're catching it early on. And it's just so much easier to treat a wound and so much faster to treat a wound when you catch it on early rather than waiting with all the complications, because the list of complications from a wound include being hospitalized for infections, long-term infections where you require IV antibiotics for weeks to months. So again, catching it early, very important. Amongst wound care, there are other things that we can do bedside. So that includes bedside ultrasounds, x-rays, blood work, EKGs, etc. So we really are bringing the entire clinic to the patient's home, and just, what's better than that? And lastly, this is all covered by insurance. So the patient is not paying a premium for getting the care to their home rather than getting to the doctors. The cost is exactly the same. So from a patient perspective, it's phenomenal for a long list of reasons. From a facility perspective, it's also very beneficial because we keep the cost low for the facilities. Now the facility doesn't have to hire extra staffing to take care of those wounds, which can be very burdensome. Not to mention the supplies for the wounds are also very costly. So the wound care clinic takes on that cost at no cost to the facility. Number two, we're keeping people out of the hospital. When your patient bounces to the hospital, not only are you increasing the costs, but Lord knows where that patient is going to bounce back to that hospital. So the facility runs a risk of actually losing the patient when they go to the hospital. Number three, you're improving ratings. Clinics, facilities don't look great when they have a ton of wounds. It's not favorable in the eyes of Medicare, and it's not favorable in the eyes of family members when they're shopping around for what facilities to take their mothers and fathers. Lastly, there is no cost or liability due to transportation. Providing transportation for patients can be costly and a big burden for just a lot of headaches on top of it to providing transportation. So, again, it's very beneficial. But on top of it, things that are sort of outside of wound care, a lot of times I have caught life-threatening diseases that are not wound care related, but just because I'm a medical provider and I'm doing a thorough evaluation of the patient, I've caught people's, medications being mismanaged, because they can't get to their doctors. Again, it falls into that. So you are catching big problems before they become a big problem. And that's an extra benefit because we're sending mid-level providers there. We're sending physician assistants, nurse practitioners who have been trained to diagnose and treat. So really there's no downside to the facility to partner up with a mobile wound care clinic because we're billing Medicare Part B. So we're not taking away from their earnings, and we're only just making them more profitable. And then lastly, from a healthcare perspective, we are keeping costs low. Even though wound care treatments are costly, it's still a fraction of the price to what it would cost to treat the patient at a hospital. We're keeping people out of the hospitals. We're keeping people from getting bad infections. We're keeping people from amputations. When you're preventing an amputation, the cost of taking care of an amputee is drastic, not to mention the quality of life of that poor patient that no one is considering. But, the life expectancy of an amputee, 5-year life expectancy is less than 50%. And that's lower than most cancers. So, cancers get a lot of attention and, we throw a ton of money at treating, rightfully so, as we should. But when it comes to wound care, all of a sudden, it's not appropriate for us to spend money to treat wound care patients when they are suffering for months and years with these open wounds. I don't understand the logic behind this proposal.
Yeah, and I think you echo a lot of us who work in the patient care space and the advocacy space. And you and I were touching on this in the green room. It's really easy to sit here as people who have access to good doctors, who this story, ended up with an unexpected home birth of my child, and my doctor just came over to visit the next day. And that was normal because she's a friend. But that's not the situation that most Americans find themselves in, particularly these, rural and blue collar Americans who have worked hard their entire lives, who have paid into the system, who have paid their dues. And now we're leaving them at a state of, hey, you have to now go to this place. You have to, find doctors that may or may not be high quality, versus going back to some of the current spirit of American nostalgia. I think of reading children's books where the doctor comes to houses and my kids are like, well, I mean, Dr. Susie comes over, but like, we still have to go to the doctor's office. And so just talking about, and this is not necessarily the direction I thought we were going to take this webinar in, talking about the compliance piece of the benefits of mobile medicine. I'd like you to just tease that out a little bit more, if you wouldn't mind, because compliance is a huge part of this. And again, it's a huge reason why there's a disparity between what hospitals are charging for the advanced wound care products that they use versus the products that mobile medicine uses, or even, in-office medicine is using. And a lot of that has to do with compliance. So could you just tease that out a little bit more for us?
Yeah. So when I actually first founded the company, a lot of people kind of just came up to me and they're like, wow, this is such an innovative idea. And my response has always been, it's really not. We're actually going back to the basics, because back in the day, the doctor used to come to people's homes and then we added just a ton of complexity. Right now, there's 10 administrators for every doctor. And then we wonder why healthcare costs are so high. So let me put it this way, when you try mobile care, you will never step foot in another doctor's office again if you have the capability not to. With mobile care, I mean, the patient is literally in their own beds, in their own comforts. And let's say, God forbid, we're stuck in traffic. It is Miami. It happens all the time. And we're running a little late. So what? The patient is watching Netflix. They're not sitting in a lobby full of other sick people waiting for you. So they are, even if you're running late, they're perfectly okay with it. But let's say that, for example, the patient says, oh, I have this to do at this time. At a traditional doctor's office, they would have to cancel their appointment. With us, we would say, okay, I will come 2 hours later because you are home, or you're 3 hours later, whenever you want. So the access to care is unprecedented. But again, one of the biggest reasons why a treatment fails, whether it's medication or some sort of intervention, is compliance, seeing the doctor regularly, doing the follow-ups. So when you eliminate that, I mean, it's not perfect, of course, because there are other reasons why wounds or treatments don't work. But compliance, again, it is at the top of the list. So when you improve compliance, you improve outcome drastically. And when you improve outcome, you're actually, again, keeping costs lower, because the patient is not getting sicker going to a hospital. The wounds are being treated faster because you have eyes on it, and it's constantly just getting better and better, and you're not having relapses. So the benefits are just drastically higher than a traditional clinic.
Mm-hmm. And, something else on compliance, this ties into some of the press releases that CMS put in, or put out with the proposed rule change. Something that, obviously the MAHA, Make America Healthy Again movement has talked a lot about as well. If we had better preventative care, right? If fewer people were diabetic, if more people, fewer people were obese, if we wouldn't have these wound care problems, which I think, from our discussions, you and I would both agree with. I would love to live in a world where fewer people have diabetic foot ulcers and fewer people have, pressure ulcers because they can't get out of bed. But, well, that's not necessarily the world that we're living in. We're living in a world where these things already happened. Now, what do we do about it? But that all ties into nutrition. And first time you and I met, we had a big talk about protein intake, and you had a patient that, there was a compliance issue with having enough protein in his system to allow his wound to heal. And can you just, touch on that story? Obviously, no patient details, which but I think it would be a good example of what compliance in nutrition, because nutrition is a huge part of MAHA, looks like in the actual patient care environment.
So for starters, regarding MAHA and preventative care, my response is we can walk and chew bubblegum at the same time. We can work on preventative care while also being deep in the trenches and treating the patients that are currently sick, because we can't discard those just because they haven't had healthy food their entire life. You're not changing that now. So what are we doing right now? Right this second, how are we treating this poor patient that has a gaping wound about this big and has been suffering for it for 8 months? Preventative care ain't fixing that now. So when it comes to mobile care, when it comes to reimbursements, because the reimbursements are favorable, it allows us to have a very sort of white glove treatment with the patients, because now we are not in a rush to see patients at a volume, which is what happens when you go to an urgent care. They're making a tiny bit of money. And as a result, they're forced to see patients every 10 to 15 minutes. And you can imagine the type of quality of care that you're getting. You can't afford that type of care when it comes to complex wounds like that. So because I get reimbursed well, now I have the time to spend all that undivided attention to the patient. And as a result, you can start treating other things like managing their diabetes, managing their diet, managing their physical activity. Because in order for the patient to heal, you have to bring them to a healable state, right? So, one of the patient that we were talking about before is, because he couldn't get to the doctor, his insulin was off the chart, was unregulated. So his sugar levels were off the charts. So I had to fix that before I could fix the wound. The patient was not eating properly. He only wanted to eat sweets, and the poor staff couldn't handle with him, so they just gave him whatever he wanted to eat. So again, his diabetes was off the charts. But those type of patients don't heal. So I had to intervene, help with their diet, drastically increase their protein intake, which is very, very important when it comes to wound healing. And then lastly, I had to keep the patient moving. You need blood flow, blood circulation to the wounds, and being bedbound is how the wound gets started in the first place. So this type of clinic, the type of setting that as it currently exists, it allows us to have all those things for the patient, because if you don't have all those pieces, the patient will never heal. Even if they allow treatments with the skin substitutes, for example, if you don't have the time, if they don't give us the ability to have the time to spend with the patient, then we're getting nowhere.
With that, we're looking at this, change to 125 centimeters with no real other changes, right? There's no certainty for providers. There's no certainty for long-term care facilities. There's no certainty for patients that this product is even going to be, covered at $125 per centimeter. The only real change that we've seen in this, which is separate from the LCD local coverage determination that is currently proposed for January. We're kind of focusing on the fire that's closest to us here. What are some things that, if you were writing the CMS rule, without getting into pricing, let's look more at the policy side. What are some things that you would like to see in an actual CMS rule change that is advocating for patient care in America?
So to kind of explain a little bit to the audience, as it stands, the regulations on when you can use the skin substitutes, which by the way works amazing, right? So right now we have this tool that works really well. And then the CMS guidelines on when you can use this tool are very obscure, very much in the gray. And oftentimes what happens, you don't realize that you were not allowed to use that until 3 years later after you've been applying it for so many years. And then CMS comes after you for clawbacks and you get charged back 5 times what you actually earned for the patient. So as a result, a lot of doctors are very skittish about using this tool that works really well. Essentially, the industry has sort of created its own standards based on how many other doctors have been punished in the past. So doctor does this, and CMS 2 years later says, you shouldn't have used this because of this obscure reason that I never told you in the first place. Now I'm going to take all your money back. You're going to go bankrupt. So then the industry adjusts and says, okay, we can't use it for those reasons. But there should be a better system of telling the doctor when and when not are we allowed to use these products without being punished 3 years later because you did not know that you couldn't read their minds properly or their interpretations properly. So there needs to be a better sort of pre-authorization system. That way the doctors can be not handcuffed on when we can treat the patients. And a lot of times the patient, and as a result, the patient suffers because the patient could be getting better a lot faster, but because we don't know whether we're allowed to use these treatments, I sort of am hesitant and I wait until the last minute, and then the patient always suffers in the end.
Mm-hmm. Yeah, I think, again, that clarity would also cut down on some of the abuses. I'm not going to name names, but everyone is aware that DOJ has gotten involved with some bad actors in the wound care space. And, it only takes one rotten apple to spoil the bunch, unfortunately, as we've seen from some of the New York Times articles, where they're now putting these skin substitutes in the categories of expensive bandages, which is probably the most demeaning way you can describe these very miraculous, effective products. I obviously am more on the political and policy side, but since working in the space for the past 18 months, I've seen more wound pictures than I've ever wanted to see in my life. But I've also seen incredible healing. And, that gets into something that we talked about again in the green room, which is, the disparity in what it looks like for a upper middle class person to, treat their wounds versus, again, somebody who has, worked in, an industry where they don't necessarily have the best access to medicine. Can you touch on, as much as you're comfortable, just some of that discussion that we had in the green room about the disparity between treatment for some illnesses that affect everyone and then some illnesses that, technically affect everyone, but when we're looking at, a very high-end, high-income facility, you're looking at like 1% to 2% of the wounds are going to qualify for skin substitutes. They're non-healing after 30 days versus we go into lower income facilities or even, at-home treatment options, and you're looking at, 30% of these wounds are going to qualify.
Yeah, which actually, Jennings, being that you're on the policy side, I was going to ask you, what's the policy on me spamming CMS with pictures of these wounds that I'm treating every day? Maybe they'll start taking them a little bit more seriously. But
that is your First Amendment right. I'm not a lawyer, but I think I can feel pretty confident that's your First Amendment right. And if you need help finding emails, I'm here for you.
Honest to God, if you see the types of wounds that I'm treating every day, it's like something out of a Hollywood movie. And these poor patients, when I tell you that these poor patients, by the time that I get to them, they've had these wounds for months to years sometimes. I treated a patient that had an open wound for 8 years. She's been suffering with it. And what I've noticed is that when it comes to chronic non-healing wounds, is predominantly a low socioeconomic group of patients that are having these wounds in the first place. Because one of the reasons why the wound is open for so long is you don't have access to care. And there's a long list of reasons why you don't have access to care. You might be in a rural area where there's no doctors nearby. You don't have access to a doctor. So, or good nutrition, good food. Somebody that, if you're bedbound, somebody that's going to turn you every 30 minutes. There's a long list of reasons, right? So predominantly, these chronic wounds are on the low socioeconomic status patients, which is very sad. So when it comes to treating these patients of low socioeconomic, CMS overnight proposes that we cut costs by 95%. But when it comes to diseases like cancer, which affect their own mothers and fathers, there's I haven't heard any proposals of cutting, chemotherapy costs by 95%, when, again, survival rates for amputees is lower than most cancers. So whether intentionally or unintentionally, we're definitely seeing essentially a blind eye being turned towards the low socioeconomic status diseases, we'll call them. It's very disheartening to see that.
We're getting into the disparity between the hospital treatment environment and the home environment. There's a very huge difference between treating somebody in a sterile hospital and treating someone who doesn't necessarily have, the means to keep their environment sterile at their home. Even if we look at just office side of care, right? Because I can hear arguments popping up from people of, home health and mobile medicine is a luxury, which again, it's not, it shouldn't be. That's how America did healthcare forever.
But it's the same cost. It's the same cost as going to your doctor. The mobile clinics don't get paid more money.
Yeah, it's the same cost, but I can hear like the arguments of, oh, it's a luxury to be treated in your home. Just again, isn't true. But even looking at office side of care, right? If you're looking at office side of care for these products, they're still going back to their home environment where, like you pointed out, they may or may not have access to somebody who can turn them every 30 minutes. You may or may not have access to, the best food. You may or may not have access to, go in for all your treatments. There's a lot of patient access that comes into patient care. And there's definitely disparity there where, again, somebody who has lived in America their entire life, paid into the system their entire life, and they're now getting to a point where, they do have illnesses. They do have wounds. They're having these health issues. Yes, preventative care would have been great, but like you said, we can, walk and chew bubble gum at the same time. We can work on the future generations while still taking care of those who, paid their dues and paid into the system.
It's also important to keep in mind that wounds are not something that's treated inpatient. They're outpatient treatments, because a wound will take weeks to months to treat, to heal fully. So you can't keep the patient in a hospital for weeks to months till the wound is healed. So really, all wounds are outpatient clinics. Really, the job of the hospital is to make sure that the patient doesn't have any life-threatening illnesses, keep them stable, and then they refer them to clinics or mobile clinics like us to take care of it from there.
Right. And that's a great point, because a patient, might have been treated with $125 a centimeter product in the hospital, but when they get out and they go back to their senior living community, their assisted living facility, whatever that is, they do end up being treated with one of these, again, kind of national average on ASP right now is $2,400 if you look at, halfway down the list of products. So thank you for pointing that out, because I think that's an important piece is, yes, a patient might get $125 a centimeter in the hospital environment. But moving forward, they're going to be on a more costly product because there are greater needs of care. We did just get a question. This one comes from Craig Hayward. What are some of the conservative treatment options you were using? We were just getting started with our practice, and it would be helpful to hear your formulary.
So honestly, the list is very long. I think the biggest tip that I could give to a new clinic that's starting out is make sure that you get the patient in a healable state. Because if the patient is not in a healable state, then not even the skin substitutes will work. So as far as conservative treatments, I mean, there, a good debridement goes a long way. You know, as new providers, we're kind of hesitant to kind of start cutting flesh out of a human while they're still talking to you. But you got to keep debriding until you start to see blood, because if there's no blood, that means it's dead tissue, and no dead tissue is going to heal. So good debridement goes a very long way. Then after that, if it's a wound that's seeping a lot, wound vacs work really great. They have their limitations, of course. Personally, I'm a big fan of platelet-rich plasma. I've seen great results with that. But to kind of summarize all this, I would tell you not to get in the habit of having a cookie cutter way of treating patients, because every wound is different. There's pressure ulcers, there's venous ulcers, diabetic ulcers, and what works well for one doesn't really work well for the others. So having more of a personalized care for each individual patient, I've seen the best results with that. And also telling the patient that, managing their expectations, telling them that, look, we're going to try with what works with most patients. It might work, it might not, but we're going to kind of continue trying different methods until we find one that works for you. For example, wound vacs, they work well. For some patients, they're painful, or they can't fall asleep because there's a humming sound in there next to their ear all night, so they don't want to do it anymore. So conservative treatments, keeping the wound clean. I personally like to do a PCR swab on every wound to make sure that there's no bacteria, because an infected wound, which is very easy to get an open wound infected, but an infected wound is not going to heal anywhere. And that's really how you get the complications. So good debridement, managing comorbidities, and managing infections are probably my 1, 2, 3 starting steps. And then after that, with experience, you'll start to see kind of what works better for you and others. I've talked to providers, they swear by one treatment or they swear by another treatment. I think eventually they all sort of start to work, but the most important thing again is getting the patient in a position where they're able to heal in the first place.
Yeah, I think that's a great answer, and something that I believe is part of your formulary, but just wanted to touch on. And again, I'm not a lawyer. I'm not a medical professional. Not a doctor. Not a lawyer. Big disappointment. But the thing that keeps coming up in discussions with you and with other providers is how many providers, and again, I know you do this, forget that a topical antimicrobial that's compounded is going to be much more effective than, I've heard of providers trying to do oral antibiotics to treat a wound infection when there's topicals that would be much more effective. You just touch on like the importance of topicals here, because that does seem to be missed, particularly by providers who are not specialists in wound care.
So yeah, I think as a general rule of thumb, every medical provider knows that topical is always safer than oral antibiotic or oral treatments in general. And with current technology, there's a lot of pharmacies out there where you'll do a PCR swab and it'll tell you all the different microbes that are growing, and they will compound a formulary specifically for that patient. They work with pharmacists alongside infectious disease to compound an ointment that works particularly for that patient. So, that should be the starting point to go to before switching to oral. But again, not every patient is the same, right? There are limitations on when you can use when you can use an ointment versus oral. Obviously, if it's osteomyelitis, a bone infection, you have to go with the heavy hitters, with oral or even IV. An ointment won't work at that point. But as a general rule of thumb, topical ointments are always safer than oral. But that's loosely. It's very easy for me to say from 1,000 feet away, start with orals, but I think more importantly is the idea of making sure that you're managing the infection in the first place.
It. We got another
question. You'd be
surprised from Fred. Oh, go ahead.
I was going to say, I've actually heard a surprisingly, going back to those bad actors, I've was a shocking amount of doctors don't manage the infection before applying those skin substitutes, and that's kind of what's part of what's ruining the identity of wound care. Then the wound care, then that expensive skin graft doesn't work, and now CMS is pissed at everybody, rightfully so for that reason.
Yeah, and I mean, I think there's good reason to be angry if you apply, a very expensive product to an infected area and expect for it to heal.
It's
so
basic medicine.
You're
it's basic medicine. It's not that's not an expertise thing. That's basic medicine.
Yeah, and it gets back into which I think is what Craig is touching on. So this could be a good transition point for his question. That there's a requirement for 30 days of conservative care before moving into advanced therapies. And I like to think that reason is not because Medicare is hoping that the wound will magically heal, but I do think they're hoping that basic medicine is going to occur so the patient is in the best possible state to heal and accept an advanced therapy. Craig's question is, how do you balance what other wound care services or centers and providers have done compared to you starting advanced therapies like skin subs? Craig, if you're still on in the chat, are you asking for, hey, this patient received conservative care from another provider and for 30 days, and then you're coming in with the advanced therapy? Can you just drop yes or no? Because I think that's a really good topic from a rule perspective.
Yeah, I think that's kind of what he's touching base on. But in our clinic, the general rule of thumb is when you receive the patient at day zero, regardless of how much conservative treatments have been done so far, I kind of want to do my own due diligence. And again, I am cost conscious to the healthcare system. So I do want to fix the problem faster before getting into skin substitutes. So I try my own methods on day zero, because let's say that they've documented that they've done wound debridement. I don't know how good they did of debridement. I was not in that room. Just because it's documented doesn't mean that it was excellent. Because if the wound debridement was done properly, it's zero effect. It's almost as if they never did it in the first place. So again, I have no way of knowing how they did it, why they did it. So I start everyone from day zero. And once I truly see that it's really not going anywhere, then I switch to advanced treatments. But advanced treatments also include things like, collagen, platelet-rich plasma. It doesn't have to be just skin substitutes. Really, skin substitutes are the last resort. And to specify, they are the last resorts purely because of a cost analysis, not because they don't work well. If skin substitutes were free to everybody, I would start with skin substitutes, quite frankly, once you get the patient in a healable state. But because they're costly, we're cost conscious, and we should leave them as a last resort.
Yeah, and again, while we should be cost conscious, it is the resort that many patients need. And if you disincentivize providers from using them, there is a risk reward there where, again, there are clinics, and we talk to them regularly when we're trying to drum up support for comments on opposing the CMS rule change, where we'll talk to them and they'll say, hey, yeah, we actually just do honey, we do silver, we might do wound vacs occasionally. We don't want to do skin subs.
They don't want to do the liability.
They don't want the liability. But yeah, Craig touched on, he's seen some wounds that are 3 years old. Craig, I will say, what we are hearing from providers like Elon across the country is that most providers in very, very rare cases, they will accept somebody else's conservative care. So most providers are doing what Yvonne does, where they treat the first day they see the patient as day zero, and they start conservative care and they manage conservative care themselves. There are rare cases where we see providers who, they're very, very good friends with the primary care physician. They trust their notes. They trust the debridement process. They trust what's happened ahead of time. That primary care physician, whoever was initially treating the wound, just doesn't want to do substitute for whatever reasons. They pass them off. In general, best practice, and again, not a lawyer, not a doctor, not a provider of any type. What we are seeing as a best practice here at Alliance for Patient Care is to treat the first time you see the patient as day zero, unless you have very solid notes. You are basically getting a referral from a trusted source who with a job on the wound care.
There's a big financial liability to the providers when applying these skin substitutes, because again, the provider's earning about 20% of that cost. But if there's a clawback, the provider is responsible for 100% of that cost. So you're not just losing what you earn, you are losing up to 5 times what you've earned. So a single clawback could bankrupt a single practice. So even from a liability perspective, I'd like to add those extra steps where I know that I have tried everything before switching to skin substitute. So for those reasons, we start patient on day zero.
Yeah. Talking about clawbacks, we plan on having our friends from Shoreline on a future one of these webinars to talk about that, because again, we're big believers in the skin substitutes. We've seen the effects that they've had. We've seen the healing. We've seen again, it's a life-saving technology. This saves life and limb, right? Going back to the most medical training I've ever had, which was Combat Lifesaver back when I was in the Army. Your focus is life and limb, and this is a life and limb saving product. If the piece that I like, if you're okay touching on it, just some of your thoughts on callbacks, audits, clawback insurance, just some best practices that you've seen across treatments.
I wish I had some good recommendations. So I was at the wound care conference back, where was that? Somewhere in Texas. I think it was Dallas. And the takeaway point from that conference was that we're all operating in the dark. And like I said, the industry is sort of creating its own guidelines based on other people being punished, which is a crazy way of practicing healthcare, because now are we now prioritizing patient care? Are we now prioritizing clawbacks? What's the outcome here? So honestly, I don't have good recommendations, just because I too am operating in the gray. I'm operating in the dark. But some things that I am doing to ensure is excellent, cannot emphasize excellent documentation. That's what's going to make or break most of these clawbacks, is documentation. There are courses and training that you can take on how to document properly. And I would probably invest some money into those classes to learn proper documentations, because documentations can vary in the medical field. When I see an urgent care patient, the amount of documentation is far lower than when I'm documenting a wound care patient. So if you're going to invest on anything, is invest in really, really good documentation. And then along with the documentation comes taking pictures of the wound and documenting those properly as well, with each individual day that you're seeing the patient. Essentially, when you're applying whatever treatment course, if you're going to continue using that treatment course, you have to show that the wound is actually getting smaller and smaller and smaller. So that documentation validates your reasoning of why you chose that treatment course. So again, documentation.
Yeah, and for anyone who wants some more information on documentation, the last webinar we did with our friends over at Regeniscan went into a bunch of documentation pieces and best recommendations, best practices. And you can find that webinar on our website, or you can send us an email and we'll send you a link to watch that and catch up on some of those items. Yvonne, we're just about out of time. Is there anything you want to wrap up with? And, we just dropped the answer to this question, but if, there's a long-term care facility or a patient or even, another provider who wants to get in touch with you to meet that, one of our 3 objectives is connection. It's all about advocacy, connection, and education. So we'd love to get you connected with other people who may be watching. But is there anything you want to leave us with today?
So for starters, to anybody listening, if you have any questions, you have the email there, please reach out. I'd be more than happy to help. I believe in a collective collaboration for the good of the patient. It's why I started this company in this first place, is compassionate care. But what I want to leave with is, if anyone from CMS is listening to this, is just, providing some clarity on what you want the providers to do. I feel like it's the only industry out there where we're operating in the gray, and the doctors now are stuck with taking a huge financial risk to save a patient's lives. And that's not the way to practice medicine. It's quite obvious.
Excellent. Well, Yvonne, thank you for coming on today. We greatly appreciate it. Thank you for all the work you do for patients. And to everybody who joined us, have a great rest of your day. Please be sure to submit your comments to CMS by September 12th. And please encourage your patients, friends, and colleagues to do the same. Thank you, everybody.
Thanks, everyone. Have a great day.